Assalamu alaikum. I am Professor Dr. Tariq Wasim and you are watching my YouTube channel Medicine by Professor Tariq Wasim. In our previous videos, we have started with history taking or interviewing a patient. Then we talked about how to think a differential diagnosis based on that history. And then keeping that differential diagnosis in your mind, you then move on to uh, perform a physical examination. And the first component of the physical examination is general physical examination. We also demonstrated a video of a sequence of general physical examination and how to position and how to place the patient and how to look for various physical finding on general physical examination. From now onward, we'll be talking about the stepwise general physical examination, like it is customary that we start our examination with examination of the hands, then we move on to look at the face and head and neck area, and then moving down, we go for the examination of axilla, groin, shin, and the feet. Today's presentation would be on uh, examination of the hands and what to look for, what physical sign to specifically look for in that physical examination of the hands. Most of the slides in this presentation has been taken from various sources on the internet and on the various resources available. So few of them are my own. So this is how we start with that your examination. Usually it is customary to start with a handshake, and this simple handshake with your patient can give you a lot of information we'll be talking about in a moment. We also notice that what is the how is the shape of the hand and the size. Someone may have a very small hand, someone with a large bulky hands. Their palms are to be noticed. Nails are examined for various physical sign and specifically looking for clubbing. Any deformities of the hands and joints, they are noticed, and if there are any tremors, they are to be taken note of. Now, handshake gives you a lot of information. You may have a patient who has cold and sweaty hands, which usually can be a manifestation of anxiety. You can have a patient who had cold, dry hands. This may be one of the manifestation of a marked vasoconstriction or a patient being in shock, or maybe a manifestation of a Raynaud disease. Hot and sweaty hands are usually with patient with hyperthyroidism or thyrotoxicosis or Graves' disease. They may also have the warm and sweaty hands. The large, bulky hands, like spade-like hands, we call them, can be a manifestation of an acromegaly or endocrine abnormalities. Someone who make a hand, say handshake, but does not let your hand go, or it's a very forceful grip, you have difficulty in releasing. This can be a manifestation of a myotonic dystrophy, and of course, you may notice deformities of the fingers, specifically like in small joint of the hands in the rheumatoid arthritis. Shape of the hand will be demonstrating in a slideshow the various shapes of the hands which can be specifically looked for. An acromegalic patient usually have broader hands. They are thick, they are more fleshy and bulky. If you look at this slide, the hand on the left side of the screen is more bulky and broader as compared to the examiner's hand, which is on the right side. So this is acromegaly. You can notice the hand being very coarse and dry skin, very difficult. I mean, there may be slightly bulkier as well, maybe showing some edematous type feeling, and these are can be features of hypothyroidism, coarse, dry skin, and maybe a feature of myxedema. Notice these hands. The hands on the left side of the screen, the two hands, they have a long, slender fingers. They are thin, tapering. There's a laxity of the skin on the this radial border of the wrist is visible. Now, this is a classical example of a hands with the patient with Marfan syndrome, where there's an elastic tissue abnormality along with longer appendicular skeleton. Notice these hands. What is noticeable is in the hands, the lateral two fingers, ring fingers, and the little finger, they are shorter. They are shorter because of a shorter metacarpal, and this short metacarpal, fourth and fifth metacarpal, give rise to shorter fourth and fifth digits. And when a person makes a fist, the two knuckles in fourth and fifth knuckle they dip in. Now, this is a feature of pseudo hypoparathyroidism, or an Albright syndrome is another name given to it. After noticing the shape of the hands, you usually ask patient to show his palms, and in the palm you start noticing one by one. This is the first thing we notice, the how the red or pale the palms appear. A marked anemia would give them a pale appearance. Just notice the appearance of the hands in the background, the examiner's hands, the redness you notice over there versus the patient, which is like ash white. So this can be a manifestation of marked anemia or pallor. Notice this hand on the right side of your slide compared with the the one on the left side. This is markedly yellowish hand, or a marked yellow discoloration of the skin, which can be seen in patient with jaundice. Notice these hands. These hands show a lot of redness around the thumb, thenar or hypothenar area, with the central palm being pale. This is palmar erythema. And palmar erythema is because of the cutaneous vasodilatation of the hands because of hyperestrogenemia or various other hormones. And classically, this is seen in patient with cirrhosis or decompensated chronic liver disease, but can be seen in some other conditions like hyperthyroidism, sometimes even pregnancy as well. So this is palmar erythema. These hands show flexion of the this fourth and fifth digits because of the shortening of the tendons and shortening of the aponeurosis. Now, this is Dupuytren's contractures, and Dupuytren's contractures again can be one of the manifestation of chronic liver disease or decompensated chronic liver disease or cirrhosis. Now, this nodular appearance over this is an ossular node. These ossular nodes are cutaneous manifestation of bacterial endocarditis, bacteremia, and vasculitic phenomena. Now, these are the ossular nodes. Notice these hands. The hands show marked wasting of small muscles of the hands, particularly around the thenar eminence and the digits. And this kind of a marked atrophy of the small muscle of the hand can be a manifestation of a neuronal illness like motor neuron disease. It can be because of disuse. Sometimes it may also be seen in patient with rheumatoid arthritis when they have difficulty in using their hands. So this is marked wasting of the small muscles of the hands. Lower motor neuron type of wasting would give rise to this kind of appearance of the hands. So this is small muscle wasting of hands. Look at these, say, hands where there is a marked pigmentation, and the pigmentation is prominent along the palmar creases. Now, this pigmentation of the palms is maybe seen in patient with Addison's or hypoadrenalism. Notice these reddish spots over the palms, and these are Janeway lesions. Again, one of the manifestation of patients with bacterial endocarditis or bacterial endocarditis. Of course, there is marked bluish discoloration of the digits. This is cyanosis. Now, cyanosis can be peripheral or cyanosis can be central. Central cyanosis would appear on the tongue and hands as well, whereas peripheral cyanosis, which is usually because of marked vasoconstriction, is more seen on the peripheral or on the distal parts of the hands and feet. So this is bluish discoloration of the hands or digits because of cyanosis. Notice these hands. These hands show three different hues. The distal fingers are very pale white. Some of the areas are showing bluish discoloration, and then there is a bit of redness. Now, these changes, where there's a triphasic color changes, which may occur in a sequence that first they go pale white or ash white, then they become more bluish or cyanotic, and then they have a marked redness. Now, this is classical Raynaud's phenomena or Raynaud disease, where there is hypersensitivity of the vessels to cold and other various stimuli, and this leads on to triphasic color changes, and this is Raynaud's phenomena. Again, notice these flesh, this yellowish deposits all over the palms. These are the cholesterol deposits, or you call them xanthomas. A certain type of familiar dyslipidemias or hyperlipidemias or hypertriglyceridemias can lead on to this kind of uh, deposition or in the palms, which are called planar or palmar xanthomas. So this is again a manifestation of marked dyslipidemia or cutaneous deposition of this lipid materials. After looking at the palms, then you move on to look at the nails. Now, look at these nails. They are quite white, or we call them leukonychia. Leukonychia mean white nails, and white nails can be a manifestation of a nutritional deficiencies or hyperproteinemias, or can be seen in patients with cirrhosis as well. So this is leukonychia. This is again one of the manifestation that not only the digits but your fingernails can also get a bluish hue, and this is again cyanosis as it appears in fair-skinned people on their nails. Smokers sometimes they do not admit that they are smoking, or they hide it from or their family, they hide it from their physicians as well. Look at, you can notice that those who are particularly chain smokers or smoke cigarette one after the other, they get a nicotine being deposited along their nails and along their fingertips, and this is the nicotine staining because of a chronic smoking. Now, this appearance of nails, which is when their nails become spoon-like, there is a dip in the center of the nails, whether you look at it the lateral profile or whether you look at it from above. This is koilonychia, and koilonychia is one of the manifestation of marked iron deficiency anemias, can be seen in other conditions or some degenerative conditions as well. But the most classically, this finding has been associated with iron deficiency anemias. These toenails, they show a bit of hypertrophy, a lot of brittleness, and then there is some thickening, and then the irregularity. Now, this is the fungal infection of the nails, or we call them onychomycosis, can be seen in toes as well as over the hands. Notice this linear streak over the nails, and these are this whitish dotted streaks. They are called splinter hemorrhages. Note these nails which show slight pits, very minute, as if someone has, say, needlework has been done on the nails. And this pitting of nail is associated with certain diseases, but the most classical example is seen in with patient with psoriasis. The hand on the left shows nail being separated from the nail bed. and this is called onycholysis or breakdown or breakage of the nails, and this kind of there can be manifestation of a chronic malnutrition, can be manifestation of hyperparathyroidism as well. I've kept clubbing of the fingers or nails separately because that's probably the one thing which we usually look for or search for very, say, actively in patient with lung disease or in patient with heart disease or in patient with cyanotic heart diseases or chronic malignancies. So now, normally the nail has the nail itself and its nail fold has an angulation of about 160 degree. But once this tissue underneath the nail bed gets hypertrophied because of various either hypoxia or various other substances produced by certain malignancies, this tend to hypertrophy and lift the nail up. By lifting the nail up, you get a contour of the nail that normally your nail has convexity in a transverse fashion only. But if this is a the vertical, say, convexity as well, so this would give you your nail an appearance of more like, say, drumstick when it's a marked advanced one, and this is called the clubbing. Now, these are various, one, say, sign to look for, which is quite popular, is the Shamrock sign. That if you approximate your nails like this, I would note it, right? So, approximating your nails in front of you, and if you find a gap or a diamond shaped space in between the two approximated nails, it's okay. But if that space is gone, like we are talking about this space over here, and this space is gone, this shows that the patient has hypertrophy of the subungual tissue and has clubbing. Now, these are various, say, lateral profile or anteroposterior profile of patients showing clubbing. Now, clubbing and cyanosis together may be a manifestation of chronic lung disease or COPD or bronchogenic carcinoma or maybe lung pathologies. It can be a manifestation of a cyanotic congenital heart diseases. It can be manifestation of bacterial endocarditis. It can be a manifestation of, say, certain other malignancies and some GI conditions as well. So this is clubbing of the fingers. It's customary to classify this clubbing into various stages, but it's sufficient to say patient has clubbing or no clubbing. Classically, when the hypertrophy starts, the grade 1 clubbing would just show this slight fluctuation of this nail bed, which you can notice by doing a movement like this. Grade 2 clubbing would be the angle would be gone, and grade 3 there would be, say, accentuated convexity of the nail, as I've already previously mentioned, and then it would appear clubbed, and finally the grade 5 would almost give you not only the drumstick appearance, but the adjacent tissues may also show longitudinal striations in them. The other thing to notice in the hand examination is noticing the any joint or hand deformities. Now, this is you can notice the nodularity around the distal interphalangeal joint and the proximal interphalangeal joints of the both hands. This is again the distal one are usually called as Heberden nodes, and the proximal one are called Bouchard's nodes, and this is a manifestation of osteoarthritis generalized and as manifested in joint of the hands. So degenerative joint arthropathy or joint disease or osteoarthritis can manifest with these deformities of the phalanx or hands with outgrowth of some bony nodularity around the joint margins. This is a far advanced patient with rheumatoid arthritis, and this has led on to subluxation of the joints. You can start noticing from the beginning the wrist has shown an ulnar deviation, the thumb shows this Z deformity, the fingers showing both button ear and this swan neck deformities. So these are the various shapes given to notice the little finger, which has an initial extension at the metacarpophalangeal joints, then flexion at the proximal interphalangeal joint and extension at the distal. This is button-ear deformity. Whereas opposite of that, that you have an initial flexion at the metacarpophalangeal joint, extension at the proximal interphalangeal, and then finally flexion at the distal interphalangeal joint. This gives you an appearance of a swan neck or a neck of a swan, and this is swan neck deformities. Again, these are as a result of say degeneration of the and destruction of the joints by continuous ongoing this uh, process in the uh, rheumatoid hands. So this again showing it various names given to these deformities. This Butner deformity, swan neck deformity, Z deformity of the thumb, and ulnar deviation of the hands. This is rheumatoid hands or hand patient in patient with advanced, say, rheumatoid arthritis. These are nodular outbursting along the digits and tendons, and this is a classical example of tophi or gouty tophi or tophaceous gout. They can be along the tendons of the uh, long tendon flexors, or they can be at other places as well. They can also be seen at the air lobules as well. Now, these are the gouty tophi. Sometimes you have a slight, very well defined, shiny projection of the distal interphalangeal joint, which is actually a cystic ganglion of the finger. Another thing to notice is that whether your patient has showing tremors or not. By tremors, we mean that there is just a rhythmic oscillatory movement of the hands. Now, these oscillatory movement can be in the various forms. They can be in the form of, say, very rhythmic movement, tremors that can be in the form of a pyloronic movement. This tremors again can be classified into whether they are occurring at rest tremors. They are classically associated with in patient with Parkinson disease. They continuously have a tremulous hands, and they hand usually have a what we call a pill rolling type of movement. Whereas in patients with sometimes they are called postural tremors, that by attaining a certain posture, to attain a posture, they start this say intention tremors. Kinetic tremors are again when you are performing an activity, and task specific tremors like holding a cup or writing or this holding a pen, this starts initiate the tremors. Some other type of tremors include physiological tremors. They may be familial, they run in the families. Senile tremors because of old age wasting. Essential tremors again is one example of this senile tremors. And the one particular type of tremor is which we call the streaks or flapping tremors. Now, streaks or flapping tremors have been classically associated with patient with decompensated chronic liver disease or early stages of portosystemic encephalopathy. They can be associated with other illnesses. They can also be seen in sometime with early respiratory failure as well. They can be seen in not only liver failure but sometimes renal failure as well. And they are usually demonstrated by asking the patient to say keep his hand stretched, and then they would show this flapping of their hand. They could not be able to maintain the steady posture because of lack of, say, balance between the agonist and antagonist muscle, which are required for holding the maintaining a posture. Now, these are uh, the kind of things, observations which you need to make while examining the hands. So today we covered that when you are performing a general physical examination, what specifically has to be looked for while you're examining the hands. So paying a little attention to these abnormalities in the palms, in the nails, in the small muscles of the hand or the joints, presence of tremors, the whether the patients have a sweaty palm or a dry palm or a cold palm, hands are cold, or how is the handshake, would make you think of a possible underlying linkage between these findings and the disease patient is likely to have, and may help on in shortlisting your differential diagnosis which you have initially made, and make you say uh, alert that what further you have to look for. For example, you notice that your patient has finger clubbing and cyanosis, so your attention will be more on heart or lung disease. You notice that the patient has palmar erythema, so in subsequent examination, you would be focusing for a possible other physical sign of chronic liver disease. You notice that there were tremors of the outstretched hands, and the patient has a say warm, sweaty palms. You may start thinking that the patient may have thyrotoxicosis. So your further systemic examination would be guided or directed by the initial signs you picked up. So most of the time, the physical signs you only pick when once you have probably observed them earlier, and once you have seen them, and they get registered on your mind, and once you look at them spontaneously, like we call it spot diagnosis. It's all your repeated examination and practice, and of course keeping in mind what to look for. So in our next video, we will be talking about when you are examining your patient's face and head and neck, what physical sign you have to perform. We have already demonstrated in a video the methodology of examining that. In another video, we'll be talking of how to record vital signs, pulse, blood pressure. We'll demonstrate that, what are the specific things to look for, and then we will move on to our further systemic examination one by one with one system. Thank you for watching. And if you think that this material is helpful in understanding medicine or in understanding the basic medicine, we can you can recommend it to your friends, you can share it, you can subscribe to our channel, you can also uh, press a bell icon so that the next videos are you are alerted about that when our next video is coming on.